to get around these issues, and we, well, try to kill some of these zombies for good. But again, I think it's kind of always something that we have to redo. So here I'll just give some arguments for private health insurance and overlay, outline some of the evidence that we have in the book, because there's impossibly no way that I can actually cover all of this in the couple of minutes I have left. So, what are some of the arguments for private health insurance? And here I'm taking not from equity, obviously, but more from international evidence or from private, the economic side. And so those are some of the common ones, and they really make sense on the face of it. I mean, intuitively, and this is one of the reasons why these zombies are so sticky and they keep coming back, is that it really does make sense when you kind of look at it and you think, well, yeah, that makes sense to me. So the first one is, since those who go to the private sector still pay taxes, let's say if we had more of a private sector in Quebec, then we would liberate those resources in the public sector, and there would be more in the public sector. Now, this is mainly talking about duplicate private health insurance, so insurance for services that are already covered under the private system, under the public system. And following on this idea, if you take people out who can pay for it or have private health insurance out of the public system, well then that liberates spots in the public system for those who can't pay for it. And then finally, well, this is the main economic point, right? Duplicate private health insurance increases individuals' choices. So, the rebuttals. And again, this is kind of this is all in the book, in some places and others. There are 19 chapters, and it's an edited book, so I can't summarize all of my colleagues' arguments. But also it was found in the Library of Parliament brief that came out as a result in following the Shaoli decision, kind of looking at this and the impact for the Canadian system. So it's not just, again, bleeding heart academics who are leading that charge. So the first issue is that when we look at those duplicate private health insurance, what we find is that, and this is just going from evidence, again, I'm very staunchly grounded in what numbers, let's say. And so what has been found is that this duplicate private health insurance has added to healthcare spending. So there is more consumption of healthcare going on, but it does not necessarily reduce public spending. On the other hand, we have to ask also, as with any retrenchment, does that reduce the support for the public system? So there's not necessarily less money being spent, but is there less support for that system? And then if we look at the second argument, which is that there would be more spots open in the public system if we take individuals out of the public system and put them in the private system if they can afford it. A first question, and this is an equity issue, we might not care about that, but we might also care about that some, is that with this duplicate private health insurance, and I think the evidence from the family physician highlights this, individuals can be allowed to jump the queue. Now, to the extent to which we want to allow this is a societal decision, very much. And in Manitoba, so again, evidence and coming straight from Canada, it has been shown that having this sort of system increases earning times in the public sector. So it does not do what it pretends to do. And finally, and this, to me, it's not just a principle. Equity is not just a principle. It's a societal decision, and very much along the same lines as what Margaret was talking about. Duplicate private health insurance does increase individual choice, yes, absolutely, no doubt about it. But only for the wealthiest or well-positioned or with those with higher socioeconomic status. And so I think in this current economic situation, we are standing at a crossroads. And this is one instance where it might be actually interesting to look at what is being done down south, to our nearest neighbor, because there's a possibility that there are these movements that are made in the name of equity, and that we could learn to a certain extent from this. Yes?
I know you want to finish, but the argument was from the perspective of the patient. Can you elucidate a little bit about the perspective of the healthcare provider?
Which argument?
Your argument of
the
having a
individual?
dual system with insurance, and how does that affect the healthcare worker? So the other perspective.
Well, you saw, I think, the slide that I posted about the family physician talking about the challenges that they have in managing how to use their own social capital resources versus going through the regular system. That is definitely something that will put the physician in a position of having to decide how to allocate those limited resources in the face of having to deal with these different patient populations that are coming with not only, as physicians, that the individuals, I think from a practice perspective, individuals with different socioeconomic status come with different characteristics in terms of compliance and how they react to treatment. And then this would be beyond, so in the capacity of those individuals to actually comply with the treatment, given that they have or don't have private health insurance. Does that answer your question?
Well, I guess more directly of, I'm from the States, and there's a lot of times where you have to be on the phone talking to the insurance company.
Yeah.
Can you do a procedure? Can you not do a procedure? Can you prescribe this? Can you not prescribe that? So, I mean, there's other things.
Absolutely. Well, that's what I'm saying. So down the line, is this something additional in terms of the already heavy administrative burden that physicians have to go through that they want to go down the route? And when I say, so maybe I wasn't clear enough, but what I'm talking about when I say look down south is with Obama's reforms, not with the current system. So these reforms are coming at a time, so we could take the argument, we could take the route and say, well, the economic crisis is not allowing us any more spending, or we can't do anything given that this is limiting us. Or we could say, well, this is an opportunity for change, just as the NHS has done. And so I think the way we choose will determine the next decades. And so, and we might look back in a couple of years and see that we've gone a direction and that the US has gone another one, and it wasn't the one that we would expect.